First. So let us start now, Tufan sir. We can start now if you allow. Is the shared screen visible? I hope I'm audible and visible. And after record breaking 200 sessions, so we are now again in the next epoch. Welcome to 201st edition of Thursday Musings. Today's topic is very important for anyone who prescribes medicines. So how do the medicines interact with each other? Very thankful to the speaker today for choosing this very important topic. The session is being recorded. It will be put on the YouTube for later on viewing. The participants are in the mute mode. The panelists can unmute themselves. Participants can ask the question in the chat box. So with this intro, let us move to the next slide. I welcome Professor Dr. Tufan Pati sir, who is the chairman of this program. Sir, I'm handing over the session to you. Please take over.
Oh, thank you. Thank you for allowing me to unmute. Good evening. Sorry for the brief delay because I was muted and could not unmute somehow. Thank you, Alim. In the very outset, I congratulate our team members of Thursday Musings and the vibrant moderators, Dr. Alim Siddiqui, Treasurer of IPS, Dr. Amrit Patjoshi, Honorary General Secretary of IPS, and Dr. Vishal Chabra, Jubilant and ever smart, the vibrant moderators of our group. And with this, I will skip over their CVs to save time for the erudite lecture that is awaiting us. Our chairperson, Dr. Naresh Badlamani, who is MBBS from Gandhi Medical College and MD from Osmania Medical College, both at Hyderabad. He had presented research papers for Bhagavata Award and 699 and Young Researcher Award category at APA Philadelphia. And main interest, suicide prevention, MSc 2017, digital psychiatry, critical appraisal of research status. Organized and conducted suicide prevention awareness 2K Hyderabad for more than 5 years. Second Sunday of September in association with IPS Tamil State Branch, HPS. Other roles, National EC member representing South Zone IPS, ex-honorary General Secretary of IPS South Zone Branch, ex-President Hyderabad Psychiatric Society, ex-General Secretary IPS AP Combined State, ex-Chairperson School Mental Health Committee IPS, ex-Associate Professor of Oscar Medical College Telangana, now Chief Consultant Psychiatrist, Columbus Hospital, a 30-bedded Institute for Psychiatry and De-Addiction, Begumpet, Hyderabad, ex-Associate Professor, Apollo Institute of Medical Sciences, Hyderabad. Welcome, Dr. Naresh Badlamani. Next slide, please. We have with us Dr. Saurabh Tandon from Prayagraj. He is a consultant psychiatrist and treasurer of IPS Central Zone from 2019 to 2023. He is co-chairperson Human Rights Committee at IPS from 2020 to 24. He is ex-HOD Psychiatry of Government Medical College, Bandha. Welcome, Dr. Saurabh. Dr. Saurabh and Dr. Naresh, please take over the proceedings hereafter. Shaman will introduce the speaker, and Shaman, the other, will introduce the topic. We'll introduce Dr. Pankaj Sandekar. Saurabh will do, and Naresh. Naresh, Dr. Naresh Badlamani. Are you?
Thank you. Yes, I think I've just been unmuted.
Please introduce.
Thank you very much, the organizers of Thursday Musings. This is the 201 or 201st episode, and I'm very honored to be the chairperson of this episode. It has been going on since COVID, and it's really surprising and really wonderful that it has continuing for so many years post-COVID, the Thursday Musings, and it has touched every topic in psychiatry. And today's topic is being spoken by Dr. Prakash Ambekar. The secret, whatever the secret aspects of psychiatric medications. So actually, this topic was also a secret till 2 days back. But yes, I'd like to introduce Dr. Prakash Ambekar. He did his education MBBS from Seth GS Medical College, KEM Hospital, Parel, Mumbai, and MD Psychiatry from yeah, Mumbai, I think. INHS Ashwini. He has worked at Indian Navy Hospital, Kolaba, Hyderabad. Sorry, Mumbai. As a work experience, assistant professor in psychiatry at Indian Institute of Medical Science and Research, Jalna. Associate professor in psychiatry at Indian Institute of Medical Science and Research at Jalna from 18 to 2023. And currently, he is the professor psychiatry at Parmani Medical College at Parmani till date. Welcome, Dr. Prakash Ambekar, and really we are honored to have you as a speaker. And at the outset, I would like to thank again Dr. Alim Bhai, Dr. Vishal, Dr. Amrit Bhai, Dr. Tufan Pati for giving me this opportunity again and again at the Thursday musings. Initially, I was a chairperson earlier as well of some of the topics and spoken on a topic as well, and been a moderator of one topic and now as a chairperson of another topic. It's really, I'm really honored as well to be a part of this team. And I would like to hand over the proceedings to Dr. Saurabh.
Saurabh, please, please unmute and introduce the topic and separate.
Thank you, Dr. Naresh. Good evening, everyone. I'm really thankful to Dr. Tufan Pati, Dr. Vishal, Dr. Alim for giving me opportunity to chair this session. This is a very interesting topic, drug interaction in with psychiatric medicines. In the today's world, when a lot of people are coming to psychiatrists for getting the treatment, the awareness about the psychiatric diseases and taking the medicines is increased, and at the same time, misuse of psychiatric medicines is also there. We cannot deny with that. And because of all these things, the problems which are associated with the medicines are also coming in the forefront. There are a lot of patients who are taking psychiatric medicines without understanding, without identifying the fact that along with these medicines, they are also taking some other medicines for some other illnesses, comorbidities are there. And without thinking about the side effects and interaction of medicines, they start taking the medicines. And sadly, the physicians also don't bother about the upcoming problems associated with the interaction of these medicines, especially when the patient comes in the emergency wards. Rarely detailed medical history and drug history is being taken. So the identification of this problem and uh, prevention of this problem is very important. So I invite Dr. Ambedkar for giving his view and vision about this problem. Thank
you. Thank you, sir. Should I start?
Yes, please.
Any PPT to share? You can share the screen.
Good evening. Am I audible and visible?
Yes, sir, you are.
Yeah. Good evening. Thank you for the team. Thank you, Team Thursday Musings and Oriental Psychiatric Society for giving me opportunity for this presentation. Today, I am going to present on drug interactions, the secret affairs of psychiatry with medicine. The outline of my presentation will be, I will cover basic of interaction, then drug interaction, then pharmacokinetic interactions, then pharmacodynamic interactions, some case studies from my experience and summary. So interaction, for any interaction, you need at least two agents. Interaction can be significant or insignificant. When boy looking at a girl, it is not a significant interaction because girl is not reacting. So it is insignificant interaction. But significant interaction happens when boy proposes a girl. Then there is a possibility that girl will agree and they go on a date, or she will inhibit, disagree, and give tight slap or C will not say anything, just laugh and go away.
Dr. Prakash, your slides,
Interaction.
your slides are not visible.
My slides are not visible.
Screen share नहीं किया अभी आपने. Screen share has not happened.
Huh?
आपने screen share set नहीं किया.
My slides are not visible.
No, they are
No,
not.
they're not visible.
So please start the
You
screen
need
share.
to share slides somewhere.
You close down the slides and screen start sharing
Okay,
again, please.
okay, just a minute. Sorry.
Now you expand the whole screen,
Okay.
then you'll find the green button there with share screen. Expand the Zoom screen. Yeah.
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 Are they visible?
Now we are able to see it.
Sorry. So when boy looking at a girl, then it is not significant interactions, but significant. My slides are visible, right?
Yes. Now they are visible.
Yeah. So when boy proposes a girl, then there are it is significant interaction. Then there are chances that girl will either accept or give tight slap or will not say anything or go away. So these we can call it as a significant interactions. So they say that everything is fair in love and war, but why they do call this as affair? Because it becomes affair only when people know about it. Likewise, every prescription we write, every polypharmacy we write, we think it as a fair, but it becomes affair or unfair when we know about the what interaction, negative interaction has happened between two drugs. So with this unfair drug interaction can be predicted only when we know about the irrational combinations of the drug. As rightly put up by Voltaire, doctors pour drugs of which they know little to cure diseases of which they know less, into patients of whom they know nothing. So the basics of drug interaction include pharmacokinetic factors and pharmacodynamic factors. Pharmacokinetic factors is what what body does to the drug. It depends on the genetic factor, dose of drug, and plasma concentration of the drug. And pharmacodynamic factors are what drug does to the body. It depends on the therapeutic effect and various genetic and environmental factors. So pharmacokinetic interactions can be at the absorption level, protein binding level, metabolism level, and excretion level. And pharmacodynamic interactions are two drugs when interact and they cause therapeutic effect, either synergistic effect or antagonistic effect. So as this cartoon says, the top prescription is for arthritis, but it may cause heart attack. The second prescription should prevent heart attack, but it could damage your liver. And likewise, when there is liver trouble and we give medicine for liver trouble. Likewise, we tend to add up medicine. For example, risperidone is there. We tend to add triaxiphenil to avoid extrapyramidal side effects. So we tend to write many medicines in that way. So in pharmacokinetic interactions, first it changes in absorption. So metformin and proton pump inhibitors, we know that it reduces B12 absorption, and B12 is implicated in depression, dementia, and psychosis. Aspirin causes increased gastric emptying, leading to it can lead to alcohol intoxication if alcohol is consumed. Tricyclic antidepressant reduce cause dry mouth, and they reduce absorption of sublingual drugs like nitrates. Then interactions made due to displacement of protein binding. So when aspirin given when patient is on valproate, aspirin causes valproate toxicity by displacement of valproate from plasma protein sites and also by inhibition of beta oxidation. When we give valproate to the patient, when there is patient with resistant epilepsy not responding to phenytoin, when we give valproate, then there is displacement of phenytoin from plasma protein sites, and there is more free phenytoin is available, and it may cause phenytoin toxicity, and it may lead to nystagmus, ataxia, and likewise ibuprofen and omeprazole. It also displaces phenytoin and it causes increase in free phenytoin level. Most important thing is that when we are suspecting either phenytoin or valproate toxicity, we need to measure only free valproate level or phenytoin level, because total levels will be same. Only free levels will be different and increased, and they are responsible for the toxicity or the effect. The protein bound drug does not cause any significant effect on body. So biotransformation, the interactions at metabolism level, biotransformation is a process that when fat soluble toxins are converted into water soluble waste and eliminated via urine bile and stool. It consists of phase 1 and phase 2. Phase 1 is mediated through cytochrome P450 enzymes with the help of various vitamins, folic acid, glutathione, and flavonoids. Phase 2 consists of conjugated pathways like sulfation, glucuronidation, and it is also done with the help of various vitamins, minerals like magnesium, glycine, glutathione, taurine, choline. So we need to know something about this very important system, cytochrome P450 system. Cytochrome P450 system, it is basically consists of various enzymes which consist of heme thiolate superfamily, and these enzymes are present on either mitochondrial inner membrane or endoplasmic reticulum. Cytochrome P450 system is responsible for the metabolism of endogenous substances like steroids, prostaglandins, cell wall protein, and it is also responsible for metabolism of exogenous substances like toxins, carcinogens, and drugs. This system involves around 200 enzymes in all over the world or animal kingdom, and 50 plus enzymes are identified in humans, and 6 of them are responsible for 90% of drug oxidation. And important of them are 1A2, 3A4, 2C9, 2C19, 2D6, and 2E1. These enzymes are present abundantly in the stomach, intestines, liver, lungs, brain, and kidneys. We need to understand the nomenclature of this system. CY stands for cytochrome, P stands for absorption peak at wavelength of 450 nanometer. So peak absorption of that enzyme at wavelength 450 nanometer. Arabic number is given for the family, letter is given for the subfamily, Arabic numeral is given for the individual gene. So cytochrome P450 gene, letters and numerals in italics, and if there is enzyme is there, letters and numerals in non-italics. For example, CYP3A4. So 3 is family, then A is subfamily, and the gene is 4. So CYP3A4 is important, very important enzyme system which is responsible for metabolism of around 40% of drugs. CYP2D6 is responsible for metabolism of 20% of drugs. So these two systems are responsible for metabolism of around 60% of drugs. And then CYP1A, 2C9, 2B6, and 2E1 are also important. So these genes and these enzymes are non-specific. So single CYP can often metabolize many different drugs with diverse structures. Multiple CYP enzymes may metabolize single drug at different sites, and drug may metabolize at single site by several CYP450s. So because of that non-specificity, various drug interactions happen. So 80% of phase 1 dependent metabolism are mediated by P450 families 1 to 3. And there is also not only this enzyme, polymorphic forms exist. And most of the polymorphic forms are responsible for the adverse drug reactions, as well as non-responders are also responsible for these polymorphic alleles. We will see how we will see later. So polymorphism, it is basically different alleles at the same gene locus. Poor metabolizers lack functional enzymes. Intermediate metabolizers are deficient allele or carry two alleles that cause reduced activity. Extensive metabolizers are, that is normal, two normal alleles. And ultra rapid metabolizers has multiple gene copies are there. So most common polymorphism most commonly is present in CYP2D6. So if there are poor metabolizers, then no CYP2D6 enzymes are there, then drug will be metabolized by too slow metabolism will be there, then too high drug levels will be there, and there are high risk of adverse drug reactions. And this poor metabolizers around responsible for around 10% polymorphism is present in Indians. CYP2D6, if there is ultra rapid metabolizers are there are duplications of gene, which causes too rapid metabolism and then non-responders. Drugs like fluoxetine is responsible for this CYP2D6. So sometimes we get response with 20 mg or adverse effect with 20 mg, and sometimes we do not get a response at that drugs. Sometimes we might have to increase drug to 80 mg. So we need to understand the various terminologies like substrate. Substrate is a drug or compound that is identified as a metabolic target of particular enzyme. Inhibitor, drug which slows down normal activity level of that enzyme, which can, so there is increase in drug levels. It can be done with competitive inhibition when two enzymes compete for that enzyme's active site, or non-competitive inhibition when that enzyme is activated by the drug, deactivated, sorry. So we need to understand that when we add inhibitor, any drug inhibitor, inhibition is immediate with addition of inhibitor. Inhibitor drugs with short half-lives can inhibit metabolism with single dose. Inhibition with long half-life drugs may take time for inhibition. And inhibition is dependent on the hepatic blood flow and genetics. And then induction is a process in which drug drives up production of metabolic enzymes. It may take several weeks to occur, dependent on the half-life of the inducer and time needed for new enzyme synthesis. And induction involves new protein synthesis, and reversal also will take several weeks. Induction will also take several weeks. So for induction, you need at least 1 month. For inhibition, it can be process of 1 or 2 days. So what are the various important medicines which are metabolized by CYP1A2? Most important drugs are clozapine, olanzapine. Then which are inhibitors? Fluoxamine, moclobamide is inhibitor. And it causes basically increase in clozapine, olanzapine level. We know that clozapine, olanzapine many a times it causes basically OC symptoms, and we tend to add fluoxamine or fluoxetine. And because of that, it inhibits the clozapine level, and it can increase clozapine level to 3-fold to 4-fold. And there are chances that clozapine toxicity when we add these drugs, and there are chances of precipitation of seizures. So we should be mindful for that. In addition to that, even caffeine also can inhibit CYP1A2. So increasing lot of caffeine can cause increase in clozapine, olanzapine levels. Inducers like anti-epileptic, like we know that clozapine, if we go more than 400 dose, we tend to add anti-epileptic drugs. When we will add this phenobarbital or phenytoin, there are chances that it will induce metabolism of clozapine, and there are chances that there will be therapeutic failure or non-response of clozapine because of induction of metabolic enzymes. Few psychiatrists I have seen that they, because of sedation of clozapine, they tend to add modafinil in the morning. Modafinil also induces clozapine's metabolism, and there are chances that there is therapeutic failure. So instead, you can add armodafinil, because armodafinil have no induction effect on clozapine olanzapine. And we need to remember that smoking also induces CYP1A2, and it can cause drop in clozapine olanzapine levels and non-response to the treatment. Many a times we see that patients stop smoking when getting admitted, then there is basically the reduced induction, and after stopping smoking, there is increase in clozapine olanzapine response. Then CYP2B6, bupropion, sertraline, methadone is basically metabolized through CYP2B6. These drugs are inhibited with the fluoxetine, memantine, fluoxamine, paroxetine, and these drugs are induced by carbamazepine and modafinil. 2C9 is responsible for metabolism of lamotrigine, valproate, fluoxetine, bupropion, sertraline. So this is inhibited with the fluoxetine, fluoxamine. Then this substrate metabolism of this substrate is induced by carbamazepine or St. John's wort. So when we are giving carbamazepine with either valproate or lamotrigine, we need to increase the medicines levels, because there will be reduction in their levels. 2C19 is responsible for the metabolism of escitalopram, carbamazepine, and clomipramine. And the various inhibitors are the topiramate, escitalopram itself is an inhibitor. Then proton pump inhibitors, especially omeprazole. Omeprazole is one of the strong inhibitor, especially when we give omeprazole with either escitalopram or clomipramine. Especially escitalopram, there are chances that it can cause increased level of escitalopram. There are chances of QT prolongation with this. Other PPIs like especially pantoprazole, rabeprazole doesn't inhibit. So these are the recommended PPIs of choice when we are giving specifically with escitalopram, carbamazepine, clomipramine. And carbamazepine itself induces metabolism of escitalopram, carbamazepine, and clomipramine. Then 20% of the drugs are metabolized by CYP2B6. The most important drugs are amphetamine, atomoxetine, aripiprazole, clomipramine, fluoxetine, risperidone. These drugs are inhibited, metabolism is inhibited with amitriptyline, bupropion, paroxetine, fluoxetine, and it may lead to increase in these various levels of these various substrates. Good thing about CYP2D6 is there is no significant inducer of the system. Bad thing of this CYP2D6 is polymorphism exists rampantly. So there are chances of erratic response. If there is polymorphic allele is there, then we should not get surprised even if we give single drug without any other drug. So CYP3A4 is responsible for metabolism of 40% of drugs. Various drugs metabolized are alprazolam, aripiprazole, carbamazepine, cariprazine, lurasidone, vilazodone. Most importantly, this enzyme system is present abundantly in small and large intestine. So when these medicines are given with food, there is it tends to be increase in absorption and bioavailability of that drug. Specifically, carbamazepine, lurasidone, and vilazodone should always given with food. When they are given with food, there are chances that there is increase in bioavailability because enzyme is abundantly present in small intestines. These substrates are inhibited with fluoxetine, paroxetine, and induced with carbamazepine, modafinil, phenobarbital, and phenytoin. So most important, I think it is one of the most important slide of my presentation. We need to remember this when we are giving any drug metabolized by CYP1A2 like clozapine, olanzapine, ramelteon, melatonin, then it is inhibited with caffeine. So we should avoid giving caffeine so that there are chances that increasing caffeine can increase clozapine levels. Then fluoroquinolones like ciprofloxacin, norfloxacin also increase clozapine levels and can cause clozapine toxicity. So if you want to give fluoroquinolone, you can choose either ofloxacin or levofloxacin rather than giving ciprofloxacin. And nicotine, like smoking tobacco, can induce metabolism and cause therapeutic failure. Like insulin, omeprazole also induce CYP1A2 metabolism. CYP2C19 enzyme can be inhibited. The drugs like lamotrigine valproate are basically metabolized with CYP2C9. When given with either ibuprofen or fluconazole. Fluconazole is only one azole that inhibits 2C9. All azole inhibit 2,3,4, but fluconazole also inhibit 2C9. So if you want to give antifungal agent, patient is on valproate, you try to give other azole than fluconazole. Then the patient is having epilepsy or bipolar disorder and patient is also taking AKT, then rifampicin can reduce the level of this lamotrigine valproate. So it is better to increase the dose of these drugs or monitor therapeutic levels. Then escitalopram is metabolized by 2C19, and as I mentioned that omeprazole causes inhibition and increase in escitalopram levels, and it can cause QT prolongation. Interesting fact is that omeprazole inhibits 2C19 and it induces 1A2. So increase in escitalopram level, decrease in clozapine level. It is better to use any other PPIs other than specifically use pantoprazole or rabeprazole because there is no induction or inhibition of metabolic system because of these two drugs. Carbamazepine and prednisolone also induces metabolism of escitalopram. 2D6, around 20% of drugs, especially fluoxetine, paroxetine are metabolized by this. And cocaine, methadone, ranitidine are the inhibitors of this enzyme system. There are no known inducers. 3F4 is most of the drugs in psychiatry are metabolized by this 3F4. So fluconazole and all azoles cause inhibition. So if you are you get fungal infection and you are on drugs like vilazodone, carbamazepine, or say lurasidone, you tend to there are chances that increase in that levels and maybe the toxicity of that drug. Or macrolides can cause basically inhibition of 3F4 enzymes. So we should be careful about it. And most important is all macrolides and or fluoroquinolones can cause QT prolongation also. So drugs which are, for example, quetiapine is metabolized by 3F4, and we also give erythromycin, which is going to increase quetiapine level, and also it is going to do increase QT prolongation, QTC prolongation. Quetiapine is also going to increase QT prolongation, and with that patient, if we try to give ECT, there are chances of very negative outcome can be there. So we should be aware about it. Phenobarbital and phenytoin induces metabolism of CYP3A4. So there are the how interaction happen if we add inhibitor, or if you remove inhibitor, we add inducer or remove inducer to the substrate. When substrate plus inducer or inhibitor is there, for example, fluoxetine, it is substrate also, or it can be inhibitor also. When removal of addition of inhibitor or inducer can also cause drug interaction. So, for example, inhibitor is added to substrate. Paroxetine is CYP2D6 inhibitor, but it is added to vertioxetine because of partial response to depression, and then there are chances that increased blood level of vertioxetine and side effect of that drug will be rampant. When substrate is added to inhibitor, like atorvastatin, we add to fluoxamine 3A4 inhibitor, then there will be increased blood levels of atorvastatin, and there are chances of side effect like myopathy. Then when inducer is added to substrate, when carbamazepine CYP3A4 inducer is added to clonazepam 3A4 substrate, then decrease blood level of clonazepam, and then there are chances that patient will not show significant, will be non-responder to clonazepam. When substrate is added to inducer, when diazepam is added to 3A4 inducer phenytoin, there will be decreased levels of diazepam due to induction of 3A4 metabolism. When there is quetiapine, when we add fluconazole and remove discontinue fluconazole, because of inhibitor is removed, then there will be decreased blood level of quetiapine because inhibitor increases levels of quetiapine. As I mentioned earlier, clozapine, olanzapine, if we patient is smoker, continue to smoke, decrease in levels of because of metabolism induction. When patient stops smoking, then again there is increased blood level of clozapine. So anti-epileptic drugs, the phenytoin, carbamazepine, phenobarbital, these are potent inducers. So polypharmacy, we should avoid that. Valproate, clobazam are inhibitors. Then again, the lacosamide, lamotrigine, levetiracetam doesn't have inducing effect or inhibiting effect. We can use that. Although valproate increases lamotrigine's level by inhibiting UGT, and when so we need to aware of that. But lamotrigine doesn't cause impact on other anti-epileptic drugs. When using drug interactions, we need to aware about that. We get a lot of patients with alcohol use. Alcohol is metabolized by dehydrogenase to acetaldehyde, then to acetate. But if chronic alcoholic is there, it is also metabolized through alternate routes. The major alternative route is 2E1. Then moderate alternative route is 3A4, and minor route will be 2B6. When there is, for example, patient, the substance for 2E1 are paracetamol, isoniazid, and phenobarbital. When patient is intoxicated, then there are chances that competition of alcohol with drug and reduced rates of metabolism and increased plasma levels of drugs like isoniazid, paracetamol, phenobarbital, and toxicity. But a patient, for example, a chronic alcoholic is there, we admit that patient, and patient stops consuming alcohol, he is sober now. And because of there is increased activity of CYP2E1 because of induction of enzyme by alcohol, and then patient gets fever, and we are giving him paracetamol 500, and we see that he is not responding to that drug because of induction of CYP2E1. The paracetamol is getting rapidly metabolized. So that is the reason that we might have to give very high strength of paracetamol. And likewise 3A4 also, when alcoholic patients become suddenly sober, especially admitted, then there are chances that benzodiazepines, carbamazepine, clozapine, there is a rapid drug metabolism and can lead to therapeutic failure. And we know that disulfiram reaction can be there with alcohol, drug like phenacetin, phenylbutazone, cefoperazone, chloramphenicol, or briseofluvin, metronidazole, and all these drugs can cause disulfiram-like reactions. Most important, the villain of villain, I will consider the carbamazepine. Why I will consider? Because it is enzyme inducer. It doesn't only induces enzyme of other drugs, but it causes auto-induction of enzyme. It induces its own metabolism. Then it can cause life-threatening Steven-Johnson reaction also. And it can make females pregnant by causing oral contraceptive failure also. So it is when we are doing polypharmacy, we should be very careful. Sometimes it may cause hyponatremia also and can lead to psychosis. So we should be very careful when we are using carbamazepine. With this very significant, common significant psychiatric drug-drug interaction we see in our practice are fluoxamine given when OC symptoms are there with clozapine, and there are chances of clozapine toxicity, sedation, false seizures. Especially when patient is on valproate or carbamazepine, partial response to seizures, and then we tend to add lamotrigine. Then valproate inhibits lamotrigine metabolism. We need to give half the dose of lamotrigine. For example, 200 is full dose, then maximum dose of lamotrigine with valproate will be 100. And if patient is on carbamazepine, it will induce lamotrigine metabolism. We need to give double the dose. So lamotrigine full dose will be 400 when we are giving with carbamazepine. Then fluoxetine clomipramine, since it is CYP2D6 enzyme, it increases levels of clomipramine 2 to 3 times. So when there is partial response to OCD, we tend to add clomipramine and we increase clomipramine. So fluoxetine also increases clomipramine levels and there are chances of seizures. So we need to be very careful while using these combinations. Then last part of metabolic pharmacokinetic interaction is alternation in elimination. And most important drug here is renally eliminated lithium. When it is given with either ACE inhibitors or angiotensin antagonist like telmisartan or diuretics like hydrochlorothiazide or NSAIDs, there are chances in rapid increase in lithium levels and lithium toxicity, renal injury. You know, it has a narrow therapeutic window, so we should be very careful about this. Then various pharmacodynamic interactions. Now we will focus on the what drug does to body and interactions depend on that. For example, the drugs have various side effects. We add drugs with similar side effect. For example, clozapine, olanzapine we add. Then there are, because of anticholinergic effect, there is more chance of constipation. Then there are more chance of sedation and falls. When we add amisulpride and risperidone, there are more chances of prolactin elevation. When we add either haloperidol or quetiapine, there are more chance of QT prolongation. Many times when haloperidol is added with other sometimes other drugs like macrolides, erythromycin or azithromycin or ciprofloxacin, there are chances of QT prolongation. So we should be very careful about adding these two drugs with same side effects. Then hyponatremia and delirium. When there are some SSRIs cause, we know that hyponatremia, especially in elderly. Anti-epileptics like carbamazepine, oxcarbazepine can also cause hyponatremia. The antipsychotic like olanzapine and clozapine can also implicate in hyponatremia. So if patient is on schizophrenia on olanzapine, we are adding, elderly patient is there, we are adding fluoxetine, because these two drugs with same side effects we are adding, then there are more chances that a patient is elderly, patient will land up in hyponatremia. So we should look for other alternatives like mirtazapine, TCIs, and SSRIs. In antiepileptics like valproate or antipsychotics, risperidone can be considered good medicine. In fact, you should know that though benzodiazepines doesn't cause hyponatremia, they can worsen hyponatremia. So lorazepam is one of the good drug which doesn't worsen hyponatremia, can be considered benzodiazepine of the choice. So hypertension, we know that direct effect SNRIs by inhibiting reuptake of noradrenaline, duloxetine, venlafaxine, and milnacipran can cause hypertension. Atypical antipsychotics by indirect effect of causing metabolic syndrome and can lead to hypertension. The most commonly implicated are olanzapine and clozapine. SSRI can lead to bleeding because of there is rupture in platelets. Also, gastritis can be cause for this bleeding. So, especially when they are given with NSAIDs or antiplatelet drugs like aspirin and clopidogrel, we should be aware of this side effect, and we should monitor closely, and we should possibly give proton pump inhibitors with these drugs so that there will be no gastritis and there will be less chance of bleeding. Then there are various drugs which can cause psychosis. For example, the steroids, levodopa, isoniazid, anticholinergic drugs, levetiracetam, these and various drugs of abuse can lead to psychosis. There are chances that we see that a patient is Parkinsonism and then he is on levodopa and then he gets psychosis. We tend to add antipsychotic drugs. But reduction of L-dopa, levodopa can be done, and minimum drug with minimum effect on dopamine like quetiapine or clozapine or olanzapine can be tried, so that there are no chance of worsening of the Parkinsonism. Anticholinergics are implicated in psychosis, but can worsen psychosis or cause confusion, especially in elderly patients with dementia, with delirium. So, UK has given guidelines. They have made a AEC score, like anticholinergic effect on cognition, and they, if score is 2 or 3, you should not give that patient to you should not give that drug or medicine to patient who is elderly or cognitively demented. Especially the clozapine or all tricyclic antidepressants have a score of 3. So drugs which many times I have seen prescriptions when people or psychiatrists tend to give trixapenil at night, and there are chances that patient may land up in delirium. So because trixapenil has AEC score 3. So drugs with low AEC score like risperidone, then amisulpride, haloperidol can be preferred antipsychotic agents in low doses in elderly. There are few drugs which can cause depression, like antiepileptics like barbiturates, topiramate, vigabatrin are implicated. Flunarizine, commonly drug used in migraine, can chronically given. I have seen some cases they land up in depression. Then varenicline, drug used for smoking cessation, it can cause suicidal ideation also. Beta blockers, which cross blood-brain barrier, like propranolol, then metoprolol cause depression, and beta blockers which doesn't cross blood-brain barrier, like pindolol or atenolol, doesn't cause depression. So calcium channel blockers, antihypertensives like alpha-methyl-dopa can cause depression. Then various antibiotics given for long term can lead to depression, fluoroquinolones, metronidazole, then mefloquine, amphotericin B. So when these 2-3 drugs are given together, there are chances that patient may land up in depression. So various chemotherapeutic agents, steroids, OC pills. Also, patient for acne, when we give isotretinoin, oral isotretinoin, patient may land up in depression. Recently, I have seen that one case. So I will spend 2 minutes on this new kid in the block, that is dextromethorphan bupropion combination. Dextromethorphan is good drug. Is action on basically serotonin receptors, also sigma receptors, NMD receptor. Problem with that drug is its half-life is 4 hours, and it's metabolized by CYP2D6. Bupropion inhibits CYP2D6 and it causes increase in its half-life to 22 hours. So interactions of this combination we need to remember when we are prescribing this drug. Bupropion is metabolized by CYP2B6. So memantine, ticlopidine, clopidogrel, clotrimazole, itraconazole, all azoles inhibit this 2B6, and there are chances of bupropion toxicity and seizures can be there. So we should be very aware about when we are using this combination with these drugs. Then modafinil, phenobarbital, phenytoin, carbamazepine, rifampicin induces metabolism of bupropion, and it can cause reduction in level and non-response. Dextromethorphan, when given with CYP2D6 inhibitors like paroxetine, fluoxetine, duloxetine, quinidine, then there are chances of serotonin syndrome because of inhibition of increase in dextromethorphan level because of inhibition of CYP2D6. Various pharmacodynamic interactions when given with drug which causes lower seizure threshold like clozapine or clomipramine, there are chances of seizures because of bupropion also patient prone to seizures. When given with SSRI, there can be chance of serotonin syndrome. Then given with either the clozapine or tricyclic antidepressant causing hypotension, postural hypotension, there are chances of dizziness and falls. We should be aware of it. With this, I will go to some case studies. My first case study is night falls. 60-year-old female. She was hypertensive on amlodipine 10 mg, and for psychosis she was on clozapine 100 mg and clonazepam 0.5 mg. She presented with fall at night. The reason being because of postural hypertension of clozapine and clonazepam, there are increase in incidence of falls, especially in elderly. So we should avoid, means we should give less dose of benzodiazepine as possible. And as I mentioned that if they we should use when there is less who doesn't drug with less side effect of postural hypertension. Probably amisulpride or risperidone could have tried in this case. Then 25-year-old male complains of anxiety, tremors, and palpitation. He was given escitalopram, clonazepam, propranolol, presented with erectile dysfunction. The reasons we know that escitalopram can also cause erectile dysfunction, delayed ejaculation. Propranolol also is one of the causative agent for erectile dysfunction. So probably we could avoid propranolol instead of escitalopram. We could have given either desvenlafaxine or vilazodone or ortioxetine or mirtazapine or bupropion. So depending on the patient choice and need, we should think of other medicines. Then another case, malignant without tumor. The patient was 20 years male. He was known case of schizophrenia on antipsychotic. Presented with emergency department with history of dystonia, history of consumption of 20 tablets of trinicum plus, trifluperazine 5 mg and trihexyphenidyl 2 mg, and 10 tablets of clonazepam 0.5 mg. And because of this dystonia, he was given injection phenargan, and after admission he developed fever with rigors, with sweating. His investigation CBC urine ECG was within normal limit. He was started on antibiotics and fever was not subsiding. Physician increased antibiotic and patient died after 36 hours. And after that, physician called me after why this could have happened. So there is spot diagnosis. He was suffering from neuroleptic malignant syndrome, and he could have started on bromocriptine and lorazepam. The most important thing and interaction I would like you to know that Finargan worsens NMS. It is usual tendency that whenever patient comes, any side effect, including NMS, there is our reflex tendency that we tend to give Finargan. So if you want to give any drug, you can give NMS, bromocriptine. You want to add, you can add lorazepam, but Finargan worsens NMS. You can also give trixaphenidyl for extrapyramidal effects, but Finargan should be avoided, and it is responsible for this interaction. So narrow window, 30 years old male, he was known case of bipolar disorder. On treatment with me, lithium 1200 mg, olanzapine 10 mg, lorazepam 2 mg. He complained of body ache, fever, and loss of appetite. Went to physician. Physician found that his BP was raised 160/90. He prescribed him aceclopara combination, Leoflox 500 mg, and telmisartan hydrochloride combination. And next day, patient presented with comatose condition. Probably he had seizure also. The reason, because of increasing levels of lithium, because of aceclopara combination, telmisartan, and hydrochlorothiazide, increase in lithium level almost 3 to 4 times. And because of lithium toxicity, it was found that there is increase in lithium level 3 microgram per liter, and then patient was then managed subsequently. And in fact, you should know that dehydration or hyponatremia also can cause lithium toxicity. This needs to remember, you need to remember. So with this, I finish. My last take-home message is we should follow listen strategy. We need to list drug, dose, patient chart. For prescribing any drug, we should have proper and adequate indication. As far as possible, we should use simple regimen. We need to treat multiple symptoms with single drug. And we need to educate patient about polypharmacy, drug-drug interactions, warn against herbal preparation, OTC drug. I sometimes write that don't use omeprazole, don't use, for physician's advice, try to avoid ciprofloxacin, try to avoid erythromycin, so azithromycin. So this indication we should tell the physician, and say no or avoid if possible drug with narrow therapeutic index if possible. With this, I conclude. Thank you for listening me patiently.
Thank you so much, sir. It was a very, very wonderful, enlightening presentation. So, and very presented very interestingly also. Supposedly
Yes, it was very interesting.
Very interesting.
Very exhaustive and very interesting presentation.
Yeah. Over to chairperson for their opening remarks. We take
Thank
questions.
you, Dr. Prakash. Yes, I mean, I do agree it was an extensive presentation with the micro details of going into the drug interactions as well. I mean, to tell honestly that it will be very difficult for me to remember all these interactions and all these actions of the medications to the minute level. But then I would like to mention that a bit of summary is that diseases are now more or less symptom clusters, right? And I need to tell that there are more than hundreds and thousands of genes that code for peptides and proteins to present either as symptom clusters or even side effect clusters. What it means is you are prone to have a side effect only if you have a gene for that. If you don't have a gene, you will not have that side effect. So every psychiatric medication is unique in terms of mechanism of action as well as metabolism and drug interaction. So we can't what is called as group them under one category like that. I think even those categories are going off. They don't making much meaning. And the side effects, or say the effects of GI symptoms, EPS, NMS, movement disorders are real. So when the patient does complain, just trust the patient and then act on them as well. So revisit your the whole medical chart. And drug interactions are real too. And then there are very useful apps like Hippocrates is there, Medscape is there, the drugs.com is there. So these are very useful drug interaction, what is called apps. And I think we need to use them, or we have to use them very frequently, very regularly, because our patients do have comorbidities. Our patients do take multiple drugs. I mean, ourselves, we prescribe polypharmacy. Then the patient has comorbidities of diabetes or hypertension or other illnesses. Then so the list goes on to 9, 10 medications, and then we need to. I mean, it's very difficult for us to remember the drug interactions without the apps actually. So I think we have to be more proactive and I mean, in the best interest of the practice and best interest of the patient, we need to look into drug interactions as well. Yes, Saurabh?
Yes, sir. The whatever you have mentioned about the apps is very important here, because as you know, I am not aware of about these apps which are giving us the information about the interaction of drugs. So I think it is very necessary for a doctor, any doctor, to go through all these apps, because as I'm seeing frequently, that whenever a patient goes out of my chamber, he starts googling whatever I have written to him. So in these type of situations, if he finds some drug that this is going to give some interaction, some side effects, some problem, then he's definitely going to create problem for us. So it's better that we should be prepared for dealing with all these things. And as far as the presentation of Dr. Ambedkar is concerned, it was a very nice and extensive presentation, and I would say it is an eye-opening also for a lot of for most of our psychiatric friends. And I would also congratulate him for giving the a good series of case presentations, because he has taken and he has touched almost all the commonly finding problems which we see in the emergency rooms and um, in the indoors. So thank you, Dr. Ambekar, and I would
So we do have
now,
some questions in the chat box. Can we go through the questions?
Dr. Alim, have you seen any questions in the chat box?
Yes, sir. There are questions.
Yeah.
So does oxcarbazepine have the same inducing property like carbamazepine, as by
Hmm.
Dr. Satish?
Yeah,
I
yeah.
was also thinking about that.
It is a mild inducer.
Mild.
The carbamazepine
Yeah.
is basically it is potent inducer of the enzymes. Oxcarbazepine is mild inducer. I have mentioned it is also in my anti-epileptic drug slides.
Yes,
It
yes,
is
you did.
mild inducer as
Yes.
compared to what is oxcarbazepine is bad. It has worse chance of hyponatremia is more in oxcarbazepine than carbamazepine. But the metabolism induction wise, it is less mild inducer, but it induces. It also induces.
True. I mean, in terms of hierarchy about the inducers, carbamazepine comes on the top, and
Yeah,
carbamazepine comes somewhere near the bottom as well, or in the middle.
yeah,
And in terms of inhibitors, fluvoxamine and fluconazole, they both come on the top.
yeah. Right.
And then there's the hierarchy of other SSRIs and other medications.
Yeah,
Yeah. I still remember, I'm sorry, just in coming in. I think carbamazepine is a very dirty drug. I still remember my second year of PG when I learned about this. वो दिन और आज के दिन I have not used that drug. It's been and oxcarbazepine has been much safer because of and I think that's why the use of oxcarbazepine has increased across the board throughout India. You know, I think people still use carbamazepine in Western countries, but oxcarbazepine is much better and much safer drug, definitely.
Think about
But
carbamazepine. One more prescribing tip is that it's a self-inducer as well. What
yeah.
it means is it eats itself,
Hmm.
right? So you need to start it with a little higher dose,
Hmm.
right, and then reduce the dose after 1 week or something like that.
but let us not forget that it is a very effective drug and it is a very cheap drug.
Yes.
Definitely. That is a very important point, because often we prescribe carbamazepine just because of the cost of the medicine.
But somehow, I don't know whether it's genetics or other things, I found it very useful in females. Females respond well, or they, yeah, they respond well to carbamazepine.
It's a
Okay.
nice observation.
There is a question in the chat box by Dr. Veda. thanking you for the presentation and any word of caution that we need to be careful with second generation antipsychotic depot preparations with respect to drug interactions.
Second generation, basically, it is no significant pharmacokinetic interactions, but pharmacodynamics is there are chances. Specifically, very few people are sensitive to paliperidone. Or when you are giving any depot preparation, it is better to give oral drug initially. If
Yes.
patient is tolerating, then you need to convert it into the injectable drug. For example, when you are giving 300 mg of olanzapine per month, so 300 divided by 30, it comes to 10 mg. So when your patient is tolerating 10 mg of olanzapine, then you can give him 300 mg of olanzapine, but initial concentration will be high, but it comes around the same thing. If patient is tolerating like 6 mg of paliperidone, then you can safely give 150 mg of paliperidone, Paliris LA per month, because 150 divided by 30 will come around 5. So with this, first you try to give oral dose, then minimum this thing will as minimum drugs will be there, it will be good. Especially olanzapine long acting you are giving, then patient is smoker, again it is going to reduce the level. So ask patient to stop smoking. Then patient is consuming lot of caffeine, there are chances of there is increasing olanzapine levels. So we should remember that.
I think one of the probably points which I like to add here is that I mean, probably the doubt that comes in my mind is that suppose we are giving palpidone injection. After an oral dose of palpidone, she is tolerating very well. The patient is tolerating very well. After 3-4 months of injection, then suppose do we have? I mean, suppose I have to give some erythromycin or I have to give antibiotic or antihypertensive in between the month. So how will it interact with paliperidone, or how will paliperidone act on this medication, or will they create any side effects with each other?
Chance of QT prolongation are more with paliperidone than olanzapine, right? So when you are giving the antibiotic, I have mentioned that fluoroquinolone you want to give, just avoid ciprofloxacin, just avoid norfloxacin. Try to give either leoflox or oflox. Don't give macrolide. You can give plain cefixime also, no problem. So you can give antibiotic, there is no problem. And most important, you should remember is that for inhibition, there are 2-3 days. Within 2-3 days, there is inhibition. For 5 days, of course, patient can land up in QT prolongation. For induction, it takes 1 month. So for a few days, you want to give drug which can induce enzymes. So then it is okay. For inhibitor, you should be cautious from beginning. That is take home message.
So this is
There are
in
two things
keeping
again I love to add here. One
Hmm.
is that paliperidone can, or any antipsychotic can induce what is called, or say have neuroleptic malignant syndrome at
Yeah.
any point of their course. It can be in
Yeah.
the beginning, it can be middle, it can be end. After 1 year, after 3 years, after 5 years, NMS can occur at any time. They can
Yeah.
just switch on the gene for NMS. The second is that sorry.
So
Yeah, they can have any EPS, extrapyramidal symptoms, at any time as well. Again,
but as compared to first generation, second generation are safe. At that point, if that point is concerned, then we need to prepare second generation probably.
Prakash sir,
Yes.
Prakash, can you have already talked about it. Can you once again enlist those drugs from the medicine department that should be avoided?
So omeprazole will be first culprit, and then second thing,
And
the
then
drug
what
of
to
choice,
prefer? So then what to prefer?
PPI, the lansoprazole also you should avoid. So PPI, if you want to give, I don't have omeprazole in my pharmacy. I will give rabeprazole or pantoprazole. Antibiotic, we should avoid ciprofloxacin, norfloxacin, or macrolides, because QT prolongation also and enzyme inhibition also. If you want to give from medicine department, all azoles, oral azoles, we should be very cautious. Azoles like antifungals, we should be very cautious. Ideally, if you want to give statin, pravastatin is the best drug, no interaction. Still, you can give atorvastatin also, but it is metabolized by 3F4. So inducer or inhibitor, you should be cautious. But pravastatin is this thing statin of choice. Then and for lithium, we should avoid telmisartan, captopril, enalapril, hydrochlorothiazide, NSAIDs. This is most commonly given. Writing.
Can you name the antihypertensives again? Because most of the people are using it. Tell me something you said.
ACE inhibitors, angiotensin antagonist, and diuretics. ACE inhibitor में enalapril, captopril. Angiotensin antagonist में telmisartan, all TAN group, losartan, telmisartan. And diuretics like hydrochlorothiazide and all furosemide and NSAIDs. Every NSAID, the potency-wise diuretics will increase rampantly, followed by ACE inhibitors and angiotensin antagonists, and third is NSAIDs.
Very good. Thank you. And you also said that propranolol can cause depression.
Yeah. The thing is that beta blockers which cross blood-brain barrier. So propranolol and propranolol and metoprolol cross blood-brain barrier, they can cause depression in long term. But if metoprolol doesn't cross blood-brain barrier, pindolol doesn't cross blood-brain barrier, so they don't cause depression. So so atenolol has least chance of causing depression.
Okay,
Then
I would use the word they would precipitate or trigger depressive symptoms, some of the depressive symptoms.
Yeah, in long term. And the flunarizine is one of the important causative agent for depression.
So, Dr. Prakash, when you say long term, what do you mean by long term? Like most of our patients are on, either propranolol or flunarizine for 3, 4 months, 6 months.
If ideally, what I do, if patient with migraines comes to me, if patient has predominant depression, then I add amitriptyline. Patient has predominant anxiety, I add propranolol. And if patient doesn't have anxiety depression, I can give flunarizine. But you should be basically side effect, like we see side effect profile, you should also see the comorbid profile of the patient. Migraine with depression, migraine with anxiety. And depending on, we need to add. But many patients I have seen flunarizine causing depression over period of time. They are taking treatment under physician for migraine. They are going well, headache is settled. But they come with depression. I stop this flunarizine and they become all right.
I agree. No, but I want to understand what is long term according to the textbooks. Is it 6 months, 3 months, 1 year? So that we should be
all these effects are on long term basis. Even levetiracetam causing psychosis also long term basis. And
I'm asking the duration for long term. How do you define long term?
There is no specific duration I come to know. But when you know, you are aware of it, you can look for it.
Okay.
So coming back to the topic, what are the dietary components, dietary supplements that we should be aware of in drug-drug interactions?
See, 3A4, most of the drugs are metabolized by 3A4. Grapefruit juice is, but we don't get grapefruit in India. So it is a potent inhibitor of 3A4.
Then,
Cranberry juice comes.
Cranberry juice also, I think it is 3A4 inhibitor, but I have not, basically, I did not get time to focus on that. But caffeine, I would say, yes, it affects significantly. If patient is taking caffeine, coffee regularly, daily, then there are chances that increase in clozapine, olanzapine levels.
So caffeine, smoking, dietary history should also be taken when you're working up a case.
Yeah, smoking reduces clozapine level, caffeine increases. If patient is taking both, then our response will be erratic.
Also, a lot of patients are foreign, like you mentioned about herbal preparation, OTC.
Yeah.
Herbal preparations, Ayurvedic preparations, and these homeopathy preparations.
So we should tell them to avoid, but because we don't know what it contains, everything. Many times patient ask, should I take or should, so it is, they are not scientific. So I think we should advise them not to take.
So suppose these interactions can be uh, used as a therapeutic thing. Suppose I want to increase the level of lamotrigine, so I add 200 mg of valproate.
Yeah. Many times you can give lamotrigine with valproate to increase efficacy. But what is like dextromethorphan bupropion combination works on same principle. But many times they are not scientifically studied, and there are chances that erratic increase in drug levels. So you should be cautious. Like valproate is given in lamotrigine, then sometimes it will work well. Many times I also tend to give, but sometimes there is increase in erratic levels of that drug. So we should be aware of it.
Dr. Naresh, you had mentioned few websites or few apps where you can check drug-drug interactions. People have asked in the group. Can you mention it again?
Yeah, it's Hippocrates, Medscape is one, and drugs.com is one.
Hippocrates, right?
EPO, yeah.
EPO.
CRATES.
Hippo. Not Hippo. Hippo.
You can share in the chat box, Dr. Naresh.
Yeah,
So that
sure.
we will know. Yeah.
Dr. Siddharth has asked a few quick queries. Does venlafaxine increase BP long term in some patient? Does sertraline aggravate RLS in prone patient? Can high doses of lesser activating SSRI cause middle insomnia? Can antidepressant? I think these are not focused on the current topic. Currently, we are focusing on the drug interactions.
Yeah.
If sir wants, he can take. Otherwise, we can have a separate session for this side effect profile and management of side effects.
One more query.
I think Dr. Prakash already mentioned that venlafaxine venlafaxine you said increases blood pressure.
Yeah,
right?
this venlafaxine also increases, but milnacipran on higher order.
Yes.
Followed by, because of it depends on the NRI, noradrenaline reuptake inhibition. Milnacipran higher order, followed by venlafaxine, followed by desvenlafaxine, followed by duloxetine. The order will be like this.
Actually, there are a few important questions, but they are not relevant to the topic. Suppose Asians requiring lesser doses of medications, lesser doses of antipsychotic, greater sensitivity of dopamine receptor antagonist. So, I think we should address the questions only on the topic. So, please post questions that are relevant to the present topic.
One of the lethal combinations, paroxetine plus propranolol. What is your take on it? This is Dr. Nikhil Patel asking.
I will be means I don't think it is lethal combination, but paroxetine is basically SSRI, but we can place it and on the boundary of SSRI and SNRI. In higher doses, it also inhibits non-adrenaline reuptake inhibitor, so it can increase blood pressure also. But how it is lethal, I will be not able to explain. I don't know.
Yeah, I also don't know.
I think it is not lethal.
Yeah.
We have covered all the relevant questions. So I think we can start winding up now.
Yeah.
Or has been speaking quite some time now. So over to chairpersons for their remarks. Then we go to Tufan Pati, sir.
Right. I think it was a very interactive session as well. And yes, lots of secret musings about the psychiatric medications. We did learn a lot. In fact, I learned a lot as well, including the details of the CPY system um, in the liver 450 system in the liver as well, and various enzymes, classifications of the various enzymes that are responsible for the metabolism as well, including drug to drug interactions and the various inducers and the various inhibitors of various drug interactions and drugs as well. And Dr. Prakash Ambekar, with his personal experience and his knowledge, really put life into this whole interactive session. And yeah, and finally, I thank the organizers, Dr. Aleem, Dr. Tufan Patiji, Dr. Amrit Bhai, and Dr. Vishal Chopra as well for giving me this opportunity. In fact, I really enjoyed this session as well. Thank you very much. And I will hand over to Saurabh for his final comments.
Thank you, Dr. Naresh. This was definitely a very interesting and informative session. And definitely this discussion has given a new line, a new string in deciding the combination of medicines. And there are definitely some new areas also in which we can work. As we have this time, we have discussed about the interaction of psychiatric medicines along with other comorbidities and the effect on the, basically we focused on the effect on these medicines on the body and the blood level of these drugs. The next time we can discuss about the other general medical conditions which can be worsened or go better with our psychiatric medicines. We can also think in those lines. With this, I would like to thank organizers, Dr. Vishal, Dr. Aleem, Dr. Amrit, um, and great Dr. Tufan Pati, who is doing all these things for such a long time. And congratulations for 201st session, Dr. Sir. Thanks.
Yeah.
Tufan sir, over to you.
Thank you, Dr. Ambekar, for this nice illuminative presentation. It was refreshing and awakening for most of us. But what I tend to think is that who goes in for interactive drugs? Is it with the psychiatrist always? Not mostly. Above the age of 60 to 65, many people, apart from psychiatric disease, have 4 to 5 comorbidities. And if we really take the history, when they come to us, they come with a score of drugs around 12 to 13 on their basket. In the other side, suppose we are treating a patient for a long time on a psychiatric disorder, maintaining well, he goes somewhere else and has a diabetes, blood pressure, and so he also shows their medication. So awareness of all the consultants is required. What I want to highlight about drug-drug interaction with drugs used for physical condition, it is high time to have a consultation liaison tendency, aptitude among all the medical professionals. I am treating a patient, he is having clozapine, he goes elsewhere and accidentally diagnosed as diabetes, and somehow other doctor goes in for insulin. Unaware or oblivious of the fact he's taking olanzapine or clozapine. The patient takes both the things, and it is not noticed when we go in for monitoring fasting blood sugar. And how often we do it? Hardly 6 months, never more than that. And if you go below, people will object. So that is the reality. I have found many drug interaction cases who are originated in the other chamber, not ours. So to remedy that, we have to have consultation liaison. They have to buy vehicles. As it is awakening for us, they also need awakening sessions. So I suggest we can have interactive sessions with them also. That's my opinion. And again, kudos for your nice presentation. And thanks for Saurav and Aleem and Vishal for the nice conduction. Over to Amrit. Amrit is there?
Sir, Amrit is not there. If Vishal wants, he can say the thanks.
Okay. So
And
thank you.
Odisha Psychiatric, IPS Odisha State Branch too. Okay.
So first of all, I'll thank IPS Odisha State Branch for initiating Thursday Musings, and thank you, Tufan sir, for heading this project for a long time now. Thank you, Aleem Bhai, for spearheading it, managing it. He's the main guy managing everything. Nice. Thank you, Dr. Naresh and Dr. Saurabh, for agreeing to chairing on just a single call. I think 10 seconds, 20 seconds call. Thank you so much for doing that. Thank you, Dr. Prakash, for an enlightening and amazing talk. And I hope to see you again with another talk, hopefully on a similar topic or even, another content similar. I think we need to discuss this. Such a topic, if we do it every at least 6 months, improves our practice because all of us again become very aware of drug-drug interaction. So thank you, everyone. Thank you. Good night.
Right.
Alim bhai, you can close the meeting.
Thank you, sir. Thank you, Dr.
Thanks,
Prakash.
everybody.
I think it will be a sort of reference sort of episode that we have. I think students should repeatedly listen to it.
Yes.
Thank you so much. Thank you, chairpersons. And
Thank you and all the best.
yeah.
Thank you.
Thank
Thank you,
you,
Naresh. Thank you, Dr. Saurabh. Thank you, Dr. Prakash Ambekar, for this nice presentation. We look forward to see you again.
Thank you.
Alim, bright as usual.
Thank you. Thank you. Thank you.